Good evening, friends. On behalf of Heart Failure Association of India, it's my pleasant duty to extend a very warm welcome to our esteemed faculty and to all the participants to this first certification course of heart failure organized by the Heart Failure Association of India. As you all know, we have a huge problem of heart failure in our country due to multiple factors, which I will not go into detail at this time. New treatment modalities are being discovered every day, and the last few years have been exciting times for doctors and for cardiologists treating heart failure patients. While most of the advanced facilities are easily available in several very good centers in our country, it's even more important that the basics are done right. We have good medicines, but unfortunately, not all of them are used. And if used, they're not used in adequate doses, which denies a lot of benefit which should accrue to our patients of heart failure. We also need to spend a lot more time in educating our patients in not only management, but also in the precautions, diet, and things like that that they need to take. Learning is a continuous process, and we all are learning every day. So it's very nice that Dr. Harikrishnan and his team has put together an excellent program with which we are all going to learn. And this is going to cover all aspects of heart failure in these weekly webinars. So a very warm welcome to all of you. And I would also like to inform you that this educational activity is supported by an unrestricted educational grant by Servier India, which is governed by a non-profit foundation. So with that little introduction, may I invite Professor Vijayaraghavan to start the proceedings, tell us about the scope of the problems and where we need to go from here onwards. Professor Vijayaraghavan, please.
Think about 3500 BC, a mummy was mummified, and recently they did an MRI and they could find pulmonary edema, signs of pulmonary edema in that. That's the earliest documentation of heart failure. Ever since, you know that William Harvey's description, I fortunately had the chance to handle the book of William Harvey at Royal College of London. And we know that by chance, William Withering found the English foxglove and used the tincture digitalis, which unfortunately during his time itself turned out to be rather more death causing. And William Withering died a very, very sad man. That has he created a medicine which kills more people than saves them. And then you find Venkiba coming in. Accidentally, he found that patients on cardiac syphilis, given mercurials, did produce a lot of urine, leaving edema. That is the birth of diuretics. That's probably the first time we found a drug which can be used in cardiac failure. So this was a serendipity, an accidental finding. And thereafter, series of diuretics came in for treatment, thiazides in 58, then spironolactones. And to the surprise of everybody, on December 2nd, 1967, Christian Barnard did a transplantation. And that is the beginning of looking at what could be done at the end stage of heart failure. A lot of drugs came in with increasing longevity, like ACE inhibitors and beta blockers, the angiotensin receptor blockers with neprilysin inhibitors, and lastly, empagliflozin and dapagliflozin. We have many procedures to look after patients with heart failure, like SCD, ICD, CRT, HeartMate 1, 2, and 3. And please, anybody interested in reading about heart disease and heart failure should go through the Dick Cheney's autobiography, which describes a man getting a heart attack, angioplasty, later heart block, pacemaker, the CRT, and then the HeartMate, and the ability to move around. He has gone around US for the next election propaganda, and he made it. And please remember, today, heart failure is rampaging, is increasing to a large extent because the increasing number of elderly people plus increasing number of heart disease which is being treated, ultimately reaching heart failure. That's where the importance of this particular program comes in. And welcome everybody for this program on heart failure, stressing on heart failure management.
Dr. Harikrishnan to take over the program, please.
Good evening. Now we will go to the pre-test. Actually, we planned a pre-test to have a 25 questions on different aspects of heart failure, so that before starting the program, the participants can have an overview of the data in heart failure regarding the pharmacology, what are the outcomes, like what is the outcome in a transplant or things like that. So there are 25 questions which is there on the right side of your screen. So please answer that. We will give you 20 minutes. And after 20 minutes, we will show you the answers and we will discuss for 10 minutes. After that, we will start the lectures starting with the epidemiology of heart failure. So please start answering the questions. It is just to brush up your old knowledge about heart failure. It is you can have a self-assessment alone. We are not going to see the scores of any one of you. So please go ahead and we will discuss the answers at the end of 20 minutes. Thank you.
Are the questions visible to us also?
No, I don't think it is visible to us.
Okay.
So 137 users have already attempted.
Okay.
Here we will not score, but in the post test we will score, and those who have a particular percentage only will be, so they can attempt the test any number of times and get the adequate score. So this is the way to learn. We thought this is a way to learn the score certificate. Everybody has completed, or shall we go to the answers now?
Yeah, I think so.
Yeah. So, friends, in the next 10 minutes, I will discuss the answers. Can you see my slides?
You can see up to pre-test.
Yeah, okay. Yeah. So this was the first question. Can you see the slide now?
Yeah.
Yeah. So this was the first question. What is the commonest etiology of patients admitted with acute heart failure in India? The answer is ischemic heart disease because all the Indian registries, the Trivandrum registry and the National Heart Failure Registry has shown that more than 70% of the patients admitted with acute heart failure in India has ischemic heart disease. The second commonest is dilated cardiomyopathy, and the third commonest is rheumatic heart disease. Second question, 1 year mortality of patients with heart failure according to Indian registry data. The answer is 30%. This is the data from the Trivandrum Heart Failure Registry. Shows the mortality is around 30%. Third question is, what percentage of patients who present with heart failure have preserved ejection fraction? That is the new criteria of more than 50% in a developing country like India. So that was the question. The answer is if you take more than 50% EF as the cutoff, the answer, the choice is A, 10 to 20%. 10 to 20%. It was actually 12%. If you take the EF as more than 50%. 60 to 70% will be heart failure with reduced ejection fraction. Around 20% will be heart failure with the mid-range ejection fraction, which is between 40 and 50%. Next is a 45-year-old asymptomatic gentleman evaluated prior to hernia surgery was found to have LV systolic dysfunction. That the EF is 45%. In what stage of heart failure? So basically, he is a structural heart disease, but without significant symptoms of heart failure. For example, that is the stage B, where there is LV dysfunction, LV hypertrophy. Such heart disease is there structurally, but there is no symptoms. So it is stage B of ACC-AHF. The next question is the physical sign with the least specificity to diagnose heart failure in adults. The answer is bilateral pedal edema, because there are so many other reasons for that. It is very non-specific. And the other three, positive hepatojugular reflex, cardiomegaly by a laterally displaced apex, and left ventricular third heart sound. Are the three relatively specific things for heart failure, even though it has limitations. So which of the following medications used for heart failure with reduced ejection fraction do not reduce mortality? Do not reduce mortality. That was the question. We know the disease modifying drugs. There are three: ACE inhibitors, beta blockers, and aldosterone blockers. Diuretics produce only symptomatic benefit. It produces no mortality benefit. Diuretics will produce symptomatic benefit only, but no mortality benefit. So the disease modifying drugs, ACE inhibitor, beta blocker, and aldosterone blockers reduce mortality. So which of the following beta blockers are not recommended for by societal guidelines to treat heart failure with reduced ejection fraction? We know that only the long-acting metoprolol is recommended for treatment in heart failure. That is the metoprolol succinate. The tartrate, which has to be given twice daily, is not recommended in heart failure. Carvedilol and bisoprolol are also recommended for management of heart failure. Next is a 30-year-old patient comes to emergency department with acute dyspnea. You ask for an NT-proBNP test. What value is diagnostic? So you should know that there are different cutoffs for values for BNP and NT-proBNP. For acute heart failure, it is 100 and 300. For chronic heart failure, it is 35 and 125. So the answer is 300, because the patient has come with acute dyspnea. In acute situation, we are doing NT-proBNP. So the value is 300. So next is, which among the following has the least risk of causing hyponatremia? Least risk of causing hyponatremia. The answer is Lasix or furosemide, because the other three are thiazide or thiazide-like. So thiazides cause more hyponatremia than loop diuretics, even though this is a more potent diuretic. Least risk of hyponatremia is by the loop diuretic. Next question is, what level of dietary sodium restriction will you advise your patients with symptomatic heart failure? The answer is, we ask for a sodium, dietary sodium. The answer is A, that is 2 grams per day. That is equivalent to 5 grams of sodium chloride, 5 grams of salt. So the answer is 2 grams per day. So next question is, you have started a patient on ACE inhibitor. The baseline creatinine was 1.5. So you rechecked the creatinine, it became 2 after a week. The urine output is normal, potassium is normal. So what is your plan of action? The recommendation is you continue the same dose and monitor closely, because up to 50% increase is okay, but only if the absolute value goes more than 3 milligram, then you have to half the dose. If it goes more than 3.5, you have to stop transiently. So that is how you follow up the dose of ACE inhibitor. Next is the role of digoxin in heart failure with reduced ejection fraction. So what is which is true? Which statement is true? The answer is the digoxin does not reduce mortality, but it reduces rehospitalization. So the answer is it reduces rehospitalization. The third choice is benefit heart failure patients in sinus rhythm, but it benefits patients with atrial fibrillation more than what is in sinus rhythm. The recommended dose is 0.125 milligram. Is that recommended by initial dose recommended by ESC guidelines? So the answer is B, reduces hospitalization. Next question is, your patient with heart failure with reduced ejection fraction is on metoprolol 200 milligram OD. That's the maximum dosage. Sacubitril valsartan 200 milligram BD. That is also the maximum dose. Spironolactone 25 milligram OD. But his heart rate is 82. What will be your next choice of therapy? Here we find that we have given the maximum tolerated dose of recommended dose of ACE inhibitor, ARNI and beta blocker and aldosterone blocker. Now the heart rate is higher than 70, so we have to start on a heart rate reducing drug. So the answer is ivabradine, to add ivabradine. Next question is, all among the following are physical findings used to assess fitness for discharge in a patient hospitalized with decompensated heart failure. So there are certain parameters which you assess when they discharge patients. So what is the answer? So this is normal JVP should be there, no dependent edema, no lung crepitations. These all three should be there before you discharge a patient, and attainment of normal BNP levels. That usually it is not possible. So a 30% decrease in BNP values is acceptable when you discharge a patient. So normal BNP values may not be achievable, but a 30% decrease is okay if you have the other three parameters like normal JVP, no dependent edema, no lung crepitations, and not dependent on IV diuretics. This is the criteria for discharge. So next is, what is the 10-year survival of a post-cardiac transplant in an established transplant program? Like established transplant program in many countries are there. What is the 10-year survival? So the answer is 60%. That is the 10-year survival of, and this is the data from the heart transplant registry. This is mostly from the Australian data, 60%. So which is the drug that has shown significant survival benefit in preserved ejection fraction? That is the new definition, more than 50%. So what is the answer? The answer is none of the above, because none of the drugs have been found to reduce mortality. Some drugs like spironolactone have been found to reduce hospitalizations. Like ARNI also in recent trials have shown reduces hospitalization to some extent. So none of the drugs reduces mortality. So this is a patient with heart failure with acute decompensation. BP is less than 70. What is the inotrope of choice? The answer is norepinephrine when the BP is less than 70. So the answer is norepinephrine. So next is regarding fluid restriction in heart failure. One of the following is not true. So when do you restrict fluids? fluid restriction is recommended in patients with severe congestive symptoms. That is true. It is useful in hyponatremia. That is true. Usual restriction is to 1.5 to 2 liters. Routine fluid restriction is in mild or moderate symptoms is not recommended. So that is the answer. Routine fluid restriction mild, that is a spelling mistake. Routine fluid restriction mild or moderate symptoms is recommended. That is not true. That is sorry for that mistake. Because you should not restrict fluids in a mild or moderate patients with mild or moderate symptoms. The target dose of Ramipril in patients with heart failure with reduced ejection fraction is 10 milligrams. So you have to always try to reach 10 milligram in patients when you are starting on Ramipril, if possible, by monitoring the blood pressure or postural hypotension. Regarding therapy with ARNI, which of the following is true? If the patient is on ARB, should be stopped for 48 hours before starting on ARNI. It is not required. The patient is on ARB, you can directly start. If it is an ACE inhibitor, you have to stop for 48 hours. Target dose is 200 milligram BD. That is correct. BNP should be preferred biomarker for NT-proBNP. It is NT-proBNP is the preferred marker because we know that on treatment with ARNI, BNP levels go up. And it should not be used in patient with hepatic impairment. So the answer is B. Target dose is 200 mg. Other three statements are wrong. Regarding natriuretic peptides, which is the most commonest biomarker, which is not true. It is more useful to rule out heart failure than rule in heart failure. That is true. We must use higher cutoffs in obese patients, but actually obesity, we have to use lower cutoffs. More than 75 years, the cutoff values for NT-proBNP is 1800. That is true. As the age advances, the NT-proBNP values go up, so our threshold also should be higher. It predicts outcomes both in preserved and reduced ejection fraction. That statement is also true. So the answer is we must use higher cutoffs in obese patients. Actually, we should use lower cutoffs. It is a new anti-diabetic drug which is found to be effective in heart failure, prevents heart failure hospitalization. We all know that new data is coming on SGLT2 inhibitor. So that is the answer. The dapagliflozin, the DAPA HF statement. In COVID-19, the following statements are true except. The answer is type D, because cardiac injury manifests in second week. It is a prognostic factor. Cytokine storm, you all know, that is one of the major reasons for cardiac injury. Supply-demand mismatch is a type 2 MI is one of the major reasons for cardiac injury. And type 1 MI due to atherosclerotic plaque rupture is the commonest mechanism of cardiac injury. So type 1 MI, the usual myocardial infarction due to plaque rupture or plaque erosion, is very uncommon in COVID-19. Can happen, but the most of the acute MI-like situations happen due to type 2 MI, that is a supply-demand mismatch. A 55-year-old patient with an EF 35%, on full medications like metoprolol 200, RNA 200 BD, spironolactone 25, BP 100 by 70, heart rate less than 70, 68, LBB on ECG, and survived a recent cardiac arrest. So it is basically a secondary prevention of a cardiac arrest. So we have to go for a CRTD, which reduces the mortality and also corrects the dysynchrony caused by the LBB. So CRTD has to be given in this patient. So that is the end of the questions. So any comments or
Questions
from the panel? Otherwise, we'll go to the.
We'll proceed.
Shall we go to the next talk then?
Yes. Yes.
Talk. Can you see my slides?
Yes.
Yeah.
Very good.
So, shall I start the presentation?
Yes, yes.
Okay, good evening, everyone. Next 18 to 20, I will discuss the epidemiology of heart failure. So first we will see why heart failure is important. Because heart failure has now developed as a global pandemic. With the latest 2020 data of 2.2% of prevalence in US population, if you apply that prevalence in the world population, you have around 6 million people worldwide with heart failure. 1 to 2% of the total global health expenditure is on heart failure. And then if you take the case of US, more than 10% of whatever is spent on heart disease treatment is spent on heart failure. So coming to the impact on health systems and society, we know that heart failure therapy is resource intensive. Patient will require intensive care, patient will require support by life-saving equipment, ventilation, and reach the therapy is limited because of the accessibility and affordability, which I will discuss subsequently. Need for lifelong treatment, because patient has to be on lifelong treatment in heart failure. High mortality, that is 30% at 1 year. The US and Indian data has shown that the mortality at 1 year is 30%, which is higher than common cancers like breast and colon. So mortality is high. So that is very, very important. And economic impact is high. And there is loss of productivity because the patient is continuously on symptomatic and 30% mortality at 1 year. So there is a significant loss of productivity. So because of all these factors, heart failure is very important on a health, economic, and a societal perspective. So we'll see what is the burden of heart failure in India. We don't have any real data on incidence or prevalence. We have estimates based on extrapolation of data. As I said, if you take the 2020 prevalence of 2.2%, and if you extrapolate million Indian adults, the prevalence in India could be around 17.6 million. That is 1.76 crore patients with heart failure. That is a huge burden to the. We know in the presence of the COVID-19 pandemic, we are struggling with our health system. So that is what is going to happen to the heart failure scenario also. So what could be the current burden? So before that, we have to see certain facts, because you know that as age increases, heart failure also increases. This is the US data published in this 2020. You can see that the prevalence in the 20 to 40 age group is very slow, but when it reaches more than 80, you can see that 12% of patients have heart failure, the general population. So this is the population of India in 2011 and 2051. You can see in 2011, more than 60 years, it is only 8.3, but it is going to 3 times, 21% in 2051. So naturally, the heart failure burden is going to increase because of the increase in the age of the population. Risk factors for heart failure, we know that India is a diabetic capital, 72 million diabetics. In 2007, 8.9% of the patients, projected to go to 110 million in 2040. So naturally, heart failure will go. Hypertension similarly, from 2020 to 2000 to 2025, significant rise. Obesity, India is only next to US and China in the number of obese patients. See the graph on the data on coronary artery disease prevalence. You can see that the darker the red shade, the higher the prevalence. India has a very high prevalence of coronary artery disease. We know that 70% of heart failure occurs due to coronary artery disease. This is the data from Kerala, where we have a longitudinal study of the coronary artery disease prevalence in 1993 and 2016. We can see that 1993 it was 1.4. The same population in Trivandrum we studied, it became 3.5, around 250% increase in 20-25 years. Now we can see the data on old diseases. The rheumatic heart disease, we can see that the larger the dots, higher the prevalence of rheumatic heart disease. So we can see that in India still there is a significant percentage of patients with rheumatic heart disease that contributes to the heart failure burden. Congenital heart disease, we know that many of the patients or the children born with congenital heart defects in India, like a repairable defect, like a simple VSD, ASD or PDA, may not get correct treatment at the correct time, go on develop PH and develop go into heart failure. Then there are certain etiologies more common in Indian context, like a rare cardiomyopathies in specific regions, like EMF in Kerala. Emergent infectious disease epidemic, leptospirosis had 4% complication of heart failure. Dengue fever, myocarditis is common, and COVID, we know now that significant percentage of patients have cardiac problems, around 20%, those who have succumbed to their illness. Pulmonary hypertension due to various etiologies, as example COPD. Infective endocarditis, peripartum cardiomyopathy is common in India. Aortoarteritis, very common in some parts of the country. Anemia, which contributes to the burden of heart failure or worsens the heart failure. So all these things make the heart failure a significant problem in the Indian context. So heart failure in India, we can say that we have a double burden of heart failure, double burden, because emerging new age risk factors, diabetes, hypertension, coronary artery disease, persistence of old age diseases, rheumatic heart disease, untreated congenital heart disease, COPD, all those things. So we have a double burden. So the heart failure burden is likely to be high, and we will see that how it is going to affect the Indian population. Now we will see some Indian data on heart failure. We have two registries. This is the Trivandrum heart failure registry done by us, Dr. Vijayaraghavan also has contributed in this registry. We presented it as a late-breaking trial in the European Heart Failure Society meeting in 2013. The second data set which we have is the INDER-CHF study. 858 patients from India were there. We also will share some of the data from that. And the Kerala Heart Failure Registry, Dr. Sree and his team, 7,500 plus patients. And the National Heart Failure Registry is the recent, the latest one. We are doing it. We are around 10,000 patients we have already recruited now. This is the study architecture of National Heart Failure Registry. The red dots are the nodal centers, which are the major cardiology centers across the country. And the blue dots are the participating centers. Each nodal center, we have 5 to 6 participating centers under them. And we collect 200 patients from each center. That is how we get 10,000 patients to have an equal representation of the country. The data we presented in the European Society meeting again as a late-breaking presentation. I will share some of the data. This is the data of the 6,400 patients which we had. You can see the age. Age is 60.5. The age is 60.5, mean age. Men contributed around 68.8, around 70%. Heart failure with reduced ejection fraction was the maximum, around 2/3, 65.6. Preserved ejection fraction was only 12%, as we discussed in the question. So how will we compare with our data with the other registries? The Trivandrum data and the national data, and the last pie chart is the US data. You can see both the Indian registries, the sex ratio is around 70/30. But the US, it is around 50/50. Some studies have shown a slightly female preponderance. Here in India, it is a male preponderance of 70/30. In the Indian US data, it is 50/50. Based on heart failure, with if you categorize heart failure based on ejection fraction, you can see that the last column, preserved ejection fraction, is 12 to 16%. That's 3 Indian registries. But the US data, you can see it is very high, 35 to 46. So we can say that the ejection fraction, preserved ejection fraction patients are low in the Indian setting. Age profile is also very interesting. You can see this is the data. The last one shows the Indian data, 60.5. But you can see the other columns on the left side, 72, 73. These are the first 2 US studies. The Chinese studies, again 72 years. The European study, ESC long-term, 69 years. And the other Indian studies, you can see that it is 61, 56, 64. So what we can say that our Indian patients are 10 to 15 years younger. So this has a significant public health impact because we need to treat them for long. We need to the societal impact because the breadwinner is affected with heart failure, his productivity is lost, his family is affected. So many implications of this age profile. Age distribution is also very interesting. The first one is the US data. If you take patients less than 65, you can see that in the US it is 29%. But when you come to in both Indian data, you can see that it is around 60%. So 2/3 of the patients are below 65. 2/3 of the patients, but only 1/3 in the US. If you take more than 85 years, 25% of the US data is above 85, but it is only 2.6 or 4%. Very small percentage is more than 85. It reflects the population profile, but still we have the burden in the younger population. So coming to the etiology, we discussed in the question also. Ischemic heart disease is the most common etiology, 73%. Dilated cardiomyopathy, 17%. Rheumatic heart disease around 6% of the patients. So these three contribute. Ischemic heart disease, dilated cardiomyopathy, and rheumatic heart disease contribute to the burden of heart failure, the majority of the burden of heart failure in India. So this is the comparison of ischemic etiology. The first three are the Indian studies. It is around 65%. But when you come to the Western studies, all the Western studies, it is around 50%. So ischemic heart disease, though we think that ischemic heart disease is not common in the Indian context, ischemic heart disease contributes much more to heart failure in India than compared to the Western world. Comorbidities, hypertension is 48, diabetes in 44%, chronic kidney disease history in around 9%, tobacco use in 33, alcohol use in 17, and atrial arrhythmias, atrial fibrillation flutter in around 10% of the patients. So if we compare the data with the US and the European data, the first is the Indian registry, the second and third columns are the US and European data. You can see that hypertension is significantly lower. Probably the age is much lesser, probably due to that. Diabetes is the same. Tobacco use is double. Alcohol use is half compared to the rest of the world. And the atrial fibrillation is only 10%, but it is 35 and 44% in US and Europe, indicating that probably due to the lower age of our population. Coming to the medication use. Heart failure with reduced ejection fraction, if you take the beta blocker use was around 73, ACE or ARB in 56, aldosterone blocker in 70, ARNI in only 4% of the patients, and ARNI in 4% of the patients. Beta blocker, if you take a combination of beta blocker and ACE ARB, it is around 48%. Diuretics was taken by almost all the patients, ionotropes in around 21% of the patients. So this is the drugs at discharge, 74 beta blocker, 57 ACE ARB, and aldosterone blocker in around 64%. So this is if you take a guideline directed therapy, so we define guideline directed therapy as a combination of the three: ACE inhibitor ARB plus beta blocker plus mineralocorticoid receptor antagonist in patients with heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, only 41.4% of the patients with national heart failure registry got this drug. Maybe due to many reasons, because they may have renal dysfunction, they may have hypotension. Probably we may not be able to start these drugs in all patients, but we could give only it in around 41% of the patients. And how do we compare it with the other registries? You can see that the blue bars are the ACE inhibitor. ACE inhibitor prescriptions are significantly lower compared to the other registries worldwide. The beta blocker prescriptions were almost similar. The aldosterone prescriptions were significantly higher. Probably it is less costly, and that is why we are prescribing. Coming to the in-hospital mortality, this is a comparison. The first two are the US registries, 4 and 3.8%. The next two are the European Society, 3.8 and 5.5. Can you hear? Hello?
Professor Vijayaraghavan, please mute your mic.
4 and 3.8, and the study shows 3.8 and 5.5. Compared to the National Heart Failure Registry, it is around 8.5. So our in-hospital mortality is significantly higher compared to the US and the European. almost double. We probably the 90-day mortality. The 90-day mortality, the total 90-day mortality is around 17.1%. The maximum mortality was in the reduced ejection fraction. The least mortality was in the mid-range ejection fraction, and preserved ejection fraction has a mortality around 15%. So this is the effect of guideline-directed therapy. The effect of guideline-directed therapy, you can see that the patients who had the guideline-directed therapy in heart failure with a reduced ejection fraction had a significant benefit by reducing the mortality. Who had the 3 drugs. Mid-range ejection fraction also, these 3 drugs, we cannot say that it's guideline-directed in mid-range, but still it goes with the new concept that mid-range ejection fraction is almost behaves similar to a reduced ejection fraction. So this is a 1-year mortality, 90-day mortality in the Trivandrum registry. 1 year it became 30% with the Trivandrum registry. That is only a registry which you have a longitudinal follow-up data up to 5 to 6 years now. The inter-CHF also, the 1-year mortality is around 30 to 37% in patients. The US data also shows that. Even though our in-hospital mortality was higher, the 1-year mortality was the same in the US, Europe, and the Indian data, around 30%. So 30% is the average 1-year mortality of heart failure across the world. At 3 years, our mortality was Trivandrum registry was 45, and at 5 years, we can see that 59%, almost 2/3 of the patients are not there at 5 years. So it is higher than the Framingham data, which shows that 50% mortality at 5 years. So we have around 60% mortality at 5 years. So our mortality, long-term mortality is higher compared to the Framingham data. Coming to readmissions, we know that readmissions in heart failure indicate a high risk patient. Patients who have readmissions have a higher mortality. So it impacts on hospital resources and indicates a higher risk patient. So in Trivandrum registry, 30% of the patients were readmitted, and the 80% of the readmissions were due to heart failure exacerbation alone. And readmissions higher. Those who had readmissions had a higher mortality. This was persisting even at 5 years. So those who have a readmission, even at 5 years, they have a higher mortality. Coming to preserved ejection fraction. So what is the percentage? We have already seen that 12% of the Indian population have preserved ejection fraction if you take a criteria as more than 50%. So how do we preserved and reduced ejection fraction compare? What is marked red is the differences, the salient difference. More females 43, less ischemic heart disease 74 and 56, more hypertrophic cardiomyopathy, more rheumatic heart disease, and more hypertension compared to the reduced ejection. So how will they fare, the preserved and the reduced? This is the data from the Get With guideline. That's one of the studies on heart failure from US. You can see that the two curves almost goes parallel, indicating that the mortality at 5 years in the US data is the same, preserved or reduced. So both have the same outcome. But the data is slightly different in our population. The 3-year data shows that our preserved ejection fraction patients have a slightly better outcome compared to the reduced ejection fraction. This is probably due to the presence of rheumatic heart disease in our patients, because many of the patients like mitral stenosis or valve regurgitations, they get treated early and they have a better outcome. Probably that may be the reason. So to summarize this segment, heart failure data from India: younger patients, male preponderance, ischemic heart disease is the commonest, dilated cardiomyopathy comes the next, rheumatic heart disease is still a problem, short and long-term mortality is high, 30% at 1 year, 60% at 5 years, and guideline-directed therapy improves mortality, and only 41% receives it now. And the heart failure preserved ejection fraction around 12 to 15%, but we have seen that with the limited data, better outcomes than reduced ejection fraction. This is in short what is the data on India. So now in the next 5 minutes, we will see the issues in management of heart failure in India. Issues related can be divided into accessibility, availability, and affordability, because we know that we have uneven and limited access to healthcare, overloaded public healthcare system. We know that heart failure requires intensive specialized care, which is not available everywhere, only in few major cities. Affordability is a problem. This is one of the examples of the affordability thing. And the referral patterns. This is a study by Amit Vora's group. They identified 2,002 who had cardiac arrhythmias and heart failure. Out of them, they found 46% required a device or a radio frequency ablation. They found that only 70% of them were referred, 31% of them were not referred. And of those referred, only 25% of them consulted and were prescribed therapy. And only actually 17% of those patients who actually require therapy only got the therapy. Mostly do like ICD or pacemaker, many of the patients cannot afford. So this is also some issues which you have to consider. So the burden is enormous in India, affects younger patients, issues of accessibility, affordability, and availability. So what can be done? Accessibility, we can establish centers of excellence, referral system, point of care devices, control of drug prices, generic drugs, technology like mobile phone apps, tablet-based interactive systems, telemedicine links. But the management once the disease has occurred is unaffordable and not accessible to the majority in India. So what the US has done, you can see that after the 1960s, because of the legislations, the incidence of cardiovascular disease has significantly come down. So we have to prevent. We have to start prevention initiatives, early detection and treatment. For example, acute coronary syndrome, early initiation, primary PCO or thrombolysis, pulse oximeter screening in newborns, very simple gadget. Early diagnosis and referral for pulmonary hypertension, rheumatic heart disease, insistence on secondary prophylaxis, oral penicillin, if not IV penicillin, EM penicillin. Prevention of heart failure, control of risk factors, hypertension control, diabetes control, all this have been shown to reduce the outcome of to development of heart failure. Smoking cessation, activity, healthy dietary habit, all this will help. And one thing to highlight is that we should start early in schools. For example, we can see in this chart that the development of hypertension, the detection of hypertension and diabetes happens in the 30s and 40s, the initiation. So we have to start early in schools to start screening and cultivating good habits like physical activity, fruits and vegetable intake. All this to start in schools rather than doing executive checkups, detecting these things at a very later age when already the disease is set in. So secondary prevention is very where the physicians can help the multi-morbidity. For example, we can treat all risks together. For example, statins in diabetes. Secondary prevention, rheumatic for so heart failure in India, we are different. We gentlemen, huge burden, that is, we can call it double burden facing the health system in India, affects younger ages, high mortality. Evidence-based management reduces mortality. We have definite evidence. Accessibility, availability, and affordability are issues, but prevention is the key with focus on control of risk factors. This where the second we can concentrate, we can reduce the burden of heart failure in India. Thank you. Over to moderators.
I think it is an extensive review of epidemiology of heart failure in India with a good reference to Indian heart failure, so the registry and its data, which highlights the difference in the type of heart failure in India and abroad. You find that relatively the heart failure with preserved ejection fraction has a lower incidence in India. We do not know whether this is due to underdiagnosed or not, because the frank heart failure every physician may diagnose, but with preserved ejection fraction it may not be diagnosed, and that could be one of the reasons. The fact that our younger patients die of a higher percentage due to lack of availability of drugs, devices, etc. is very important and should be stressed. So also we have to think that there are a large group of patients when you are supervised to study for that you may find ACE inhibitors and ARBs can be used only in about 54% of patients because of limitations of or contraindications. Similarly, beta blockers can be used only in 43% of patients because of hypertension, bradycardia, bronchial asthma, etc. A lot of limitations in the practical world in the use of drugs, and that has to be what is to be taught to the physician, how to overcome some of them and how to give a guideline directed therapy to them. Very good, Hari, an excellent presentation.
Dr. Animesh, Dr. Rajasekhar?
At the outset, I must say that you have taken a very great initiative and you have delivered a very good lecture on epidemiology. There are 2-3 things which comes to my mind. The prevalence, as we have taken as the prevalence of heart failure from America, it is about 2.2%. And the prevalence of heart failure is it in tandem with the rising life expectancy. In America, the life expectancy is somewhere 79.5 years, whereas in life expectancy in India, according to current data, is somewhere 69. Almost 1 decade difference is there. And also I can observe that the diastolic heart failure, prevalence of diastolic heart failure in our registry is 12%, whereas in America and American and European data, it is somewhere 40 plus. So don't you think that we need to readjust our prevalence, because 176 million population, if we extrapolate to Indian population, 176 lakh people means 1.76 crore people are suffering from a kind of heart failure. It appears to be me a bit overestimation of the problem. Number 2 issue that I've seen from the US registries and European registries, the heart failure registries, they have enrolled almost in the tune of 1 lakh, whereas we have registered almost 10,000 patients. We have registered 10,000 patients. Now, our population is almost 3 times the American population. Don't you think that we need to increase the number of enrollments in our heart failure registry to have a better and wider thing so that we can get some statistical inertia on the claims that we are making?
Regarding the first question, what you said is correct. In the sense that our age, the life expectancy is much lesser, and as I have pointed out, as age advances, the heart failure prevalence increases. So it may not be 2.2% in India; it must be much lower. But we don't have any estimates. Whatever true is, that's why I said that approximate value must be. That is how we can project. Because we are in Trivandrum Medical College is doing another study on the community prevalence of heart failure, and All India Institute has done a study, and they found that community prevalence 1%, so 1 in 1,000. So that is the 10 per 1,000. So that 6% was having a preserved ejection fraction. So that is some discrepancy in the data. But we have to have a large community study to find out actual prevalence. The second is that 10,000 patients is a small number compared to the Indian population. We are planning to recruit more patients into the registry probably, and we are compiling the different which is happening in different parts of India. And we will, once we compile, we will get around 25 to 30,000 patients. Probably that will give a better insight into the heart failure.
One more thing which is coming to my mind, you see, sir, the perception of heart failure and the disease as such is very different in Kerala, where the literacy rate and education and health facilities are different. Whereas the perception of heart disease and heart failure in particular is very different in parts of UP and Bihar and many other Odisha and other places. So don't we think, I mean, we should include the educational part or the perceptive part of the heart failure in our registry?
Yeah, we are capturing the educational and we are capturing the different states according to their ETL, that is the epidemiological transition levels. We will have that data available once we have the full follow-up also into the system. So we will do that.
Okay, thank you, sir. I think it's a wonderful talk.
Dr. Rajasekhar.
Yeah, I just wanted to raise one point. Like oftentimes we see heart failure with reduced ejection fraction, but occasionally we find with our treatment some of these patients they improve from reduced ejection fraction to moderate range or even to normal ejection fraction. So in the three registries that we have, that is the Kerala registry and the Trivandrum registry and the national registry, how often this phenomenon is seen? The documented reduced ejection fraction during follow-up recovers to become normal ejection fraction.
We don't have the exact data, but there are a significant group of patients from reduced ejection fraction go to the mid-range. And that is the most common finding. That is why the mid-range ejection fraction is almost similar, behaves almost similar to the reduced ejection fraction in terms of the response to the treatment by the three drugs, ACE inhibitor, beta blocker, and aldosterone blocker. Probably that is very common. Very rarely patients go from the reduced to the almost normal, except in some myocarditis or some peripartum cardiomyopathy. They will I don't know the exact figures because we don't have that much numbers to say, and that much longitudinal follow-up data because to get a follow-up data of echo in all the patients is significantly difficult in the Indian situation. But that is very true. That is a very nice point, and that happens in the course of the illness. But the thing is that the TRED-HF study has shown that even if the ejection fraction improves, you cannot stop the drugs. But they have done a very beautiful study, the TRED-HF study, showed that once the patient, even though he has improved, like a peripartum cardiomyopathy or myocarditis, even if you stop the drugs suddenly, there is a chance of recurrence of heart failure in around 45% of the patients. So even though they have come to the mid-range ejection fraction or up to the normal, then you have to continue the drugs for a significant period of time. We don't know how long. So that is.
Regarding this sex difference, it is believed that as the age advances, the frequency of heart failure is more in women as compared to men. Is it so in our data also?
We don't have that, that age analysis. But in the US data, the sex as age advances, in the US data, as age advances, the males have slightly more, after the 80s, the males are slightly more with heart failure compared to the females. But in between that, the 60s and 70s, females are more than men. Okay, shall we move to the next talk?
I think there was some question at the name of autobiography book. It is Dick Cheney's autobiography. Dick Cheney was the former vice president of the United States of America. He suffered from a heart attack. Then he had a angioplasty. Then he had a pacemaker. I told you, he had every mode of treatment after transplantation. And he finally said, "What a relief after transplantation. Phenomenal relief." Thank you.
Okay. Manjunath sir, welcome to the group.
Yeah, nice seeing you, and heard your exhaustive and very highly informative, and probably because you are the one who has taken a lead in all this heart failure registry. So and also nice to see Professor Rajasekhar, Professor Vijayaraghavan. Yeah. So let us go ahead with my talk, or should we wait?
I think next is Dr. Sastry is speaking on the pathophysiology. After that, it is your.
Okay, fine, no issue.
Dr. Sastry, can you start your talk?
Yeah. Good evening, everyone. I suppose I am audible and slides are visible. First of all, I will thank Professor Harikrishna for giving me this opportunity. So now we'll proceed with my talk.
Little louder, sir.
Yeah. Is it okay now?
Yeah, better.
Yeah. Next few minutes, I'll be talking about the pathophysiology of the heart failure. Having got the introduction about the topic from Harikrishnan, let us proceed. First of all, what is heart failure? Most of the audience would know. There is no need to elaborate much on that. But I should mention this audience is a good mix of cardiologists, physicians, so general practitioners. So it may be difficult to make it. It may be difficult to present the topic which is conducive to everybody. Now, basically, what is heart failure? It is a syndrome, a constellation of signs and symptoms due to various etiologies. The basic theme is there is an impaired pump function. There is a failure to maintain adequate circulation, and this leads to congestion. Now, this is a clinical diagnosis based on so many criteria. So this may be heart failure with reduced ejection fraction, as Professor Harikrishna was mentioning about ejection fraction less than 40%, then 40 to 50% is mid-range ejection fraction, and heart failure with preserved ejection fraction more than 50%. We'll go more into details about what causes each one of them. Then equally important to know basic things like left and right heart failure. We know left heart failure leads to systemic hypotension, systemic hypoperfusion, cold climbing extremities, low output state, fatigue, whereas the right heart failure also more of low output state and fatigue, but the symptoms will be left heart failure will be more of pulmonary condition, whereas right heart failure will be more of systemic condition. Now, it may be forward failure or backward failure. Forward failure is the signs and symptoms are due to the decreased cardiac output, like fatigue and hypotension and decreased urine output. Whereas the backward failure is basically because of the congestive symptoms. In the lungs, we have got breathlessness, orthopnea, PNDs, whereas in right heart failure, backward failure will be manifest as elevated jugular venous pressure, hepatic congestion, anorexia, nausea, right upper quadrant pain, and systemic swelling, body swelling, to edema of feet and puffiness of face. It may also be because of high output or low output failure. Nowadays, we see high output failure very uncommonly, but high output failure can be because the failure, even with the maintaining high output, the systemic perfusion is not maintained and congestive symptoms will be there. This is typically seen in beriberi, thyrotoxicosis and Paget's disease, which are very uncommon. Whereas the low output failure is one which we see very often. Now, simply a cartoon here shows the systolic heart failure or heart failure with reduced ejection fraction, where the heart chambers are dilated and ejection fraction or the systemic perfusion is much less. Whereas the diastolic heart failure, the heart chambers are not dilated. Instead, there may be hypertrophy of the ventricles and dilatation of the atrial chambers, and heart cannot fill. In heart failure with reduced ejection fraction, heart cannot pump, whereas in preserved ejection fraction, heart cannot fill. Now, the basic concepts you should have before we proceed about the pathophysiology. I suppose everybody knows about what is ejection fraction, but just to recapitulate, it is the fraction of the blood of the end dash, the blood accumulated in the ventricular chambers at the end of diastole, which is ejected. Now, cardiac output is the quantity of the blood pumped by the heart per minute. It is calculated by stroke volume into heart rate. Stroke volume is per beat how much the blood is ejected into heart rate, and this should be sufficient to meet the metabolic needs of the body. And if it doesn't meet, it leads to heart failure. Now, the stroke volume, if you recapitulate physiology, is determined by preload, afterload, and myocardial contractility. Preload is the amount of blood to start with before the onset of systole, whereas the afterload is the pressure against which the ventricle has to pump after the onset of systole. And the contractility is the inherent contractility of the chamber muscle, and all these three things decide how much will be the stroke volume. More the preload, more will be the stroke volume. Higher the afterload, lower will be the stroke volume. And again, contractility, higher the contractility, higher will be the stroke volume. Now, stroke volume and heart rate they combine, when they are multiple, they give the cardiac output. Generally, heart rate is not a determinant of the cardiac output, except when it is high or too low. For example, when somebody has bradycardia, sometimes severe bradycardia, 6 syndrome, they can manifest with heart failure syndromes. Similarly, heart failure, atrial fibrillation or sinus tachycardia, extreme atrial arrhythmias can precipitate heart failure. Again, the heart failure syndrome is also determined by valvular incompetence, synergy of the LV contraction, for example, bundle branch block or interventricular conduction defects, and integrity of the left ventricle. All these determine what is the cardiac output in these patients, in our patients. Roughly, to go through classification of the heart failure, the heart failure can be classified, stages can be there, and NOHA functional classification. These are two different concepts you should know. Probably this will be talked more in the clinical evaluation. But to give an introduction, the stages of the heart failure can be A, B, C, D. This is different from the NYHA classification. The stage A is when the person is at risk for heart failure with structural heart disease, but no symptoms of heart failure. Somebody may have valvular heart disease or may have hypertension or diabetes. So that is stage A. Sorry, the valvular heart disease, presence of valvular heart disease will become stage B. For example, somebody may have hypertrophy of the chambers or valvular heart disease or myocardial infarction without any signs and symptoms of the heart failure. That is stage B. The stage C is structural heart disease with manifest symptoms, with current symptoms or even treated for heart failure. That is stage C. Whereas stage D is the refractory heart failure requiring specialized interventions. This is different from the NYHA class, which all of us know from our first year medical clinical years. The no limitation of physical activity is class 1, some limitation is class 2, marked limitation is class 3, and no activity can be done is the functional class 4. Now, as the myocardial dysfunction insult increases, we move from stage A to D. First is the stage A is predisposed for the heart failure. Then on that, the myocardial insult comes like myocardial infarction or aggravation of the heart failure or hypertrophy of the chambers in hypertension. This leads to some amount of myocardial dysfunction, stage B. Then the person gradually moves on to spiral down to stage C, that you can see here. As the stage C comes, the neurohormonal activation and altered gene expression comes, the heart failure symptoms get manifest. And it progresses to stage D or refractory heart failure. Then you have to think of the various end of the heart failure treatments. Here you can see the geometry over period of time changes. This we'll discuss more in next slides. Now, what are the different heart failure models? Professor Vijayaraghavan is mentioning about the history of the heart failure treatment. Very early stages in the 1940s, predominant thinking was the cardiorenal model with decreased urine output. People are giving treatment treated with digoxin and diuretics, that's all. Later, we thought of hemodynamic model, that is the vasoconstriction and vasodilatation, and people are treated with vasodilators like isosorbate dinitrite and hydrogen and inotropes. Then came late 80s and 90s, neurohormonal model, where we are thinking in terms of the renin-angiotensin system, sympathetic nervous system. And today, the further advances, we are thinking in terms of the future will be in terms of the genetic changes and molecular changes in the heart failure. Now, what actually happens whenever there is a left ventricular dysfunction, systolic dysfunction, cardiac output decreases, and this leads to low blood pressure. And body, as such, looks at the heart failure as a threat to maintain the blood pressure. Because there is a threat to maintain blood pressure, it immediately calls forth activation of the sympathetic nervous system, activation of the renin-angiotensin system, and activation of the arginine vasopressin system. These are all the evolutionary mechanisms to maintain the blood pressure. Because of the decreased cardiac output, there is a carotid sinus firing is decreased, the baroreceptor sensitivity is altered, and there will be increased sympathetic discharge. This immediately increases the force of left ventricular contraction, increases the heart rate, causes the venoconstriction, and increases the preload, and it also increases the afterload in a measure to increase the blood pressure. Because the cardiac output is decreased, there is a decreased renal blood flow, increased renin synthesis, increased angiotensin synthesis. This leads to increased fluid retention, vasoconstriction, and later on remodeling also. We see it in detail. The renin-angiotensin system, as I mentioned, the renin is secreted from the kidneys because of the low output, because of the decreased renal blood flow. it converts angiotensin to angiotensin 1 and then angiotensin 2. Angiotensin 2 works on the angiotensin 1 receptors, is one of the very potent vasoconstrictor. This leads to vasoconstriction and increased afterload to maintain the blood pressure. It also leads to fluid retention because of the renin-aldosterone axis, and leads to oxidative stress, cell growth, proteinuria, LV remodeling, and vascular remodeling. And increased sympathetic nervous system will increase the myocardial contractility, and also it will aggravate the renin-angiotensin system. This leads to myocardial increased contractility, vasoconstriction, sodium retention, and on the heart, the increased sympathetic activity over a period of time leads to myocardial toxicity and arrhythmias. And as the cascade goes, the disease progresses. And other aspects of the neurohormonal mechanisms will include direct toxicity of the activated renin-angiotensin system on the myocardium. This leads to necrosis over a period of time. This also leads to increased ischemia and energy depletion. And altered gene expression leads to apoptosis of the programmed cell death. And this leads to cell growth and remodeling. And all these cause ventricular remodeling, which we'll see in more detail. And as the chamber size increases because of the increased preload and decreased contractility, the ventricular and atrial stretch increases. This leads to the liberation of the atrial and ventricular natriuretic peptides, brain natriuretic peptide, and this will lead to compensate for the fluid heart failure and cause vasodilatation and increased urinary sodium excretion. But at any stage of heart failure, these mechanisms of the natriuretic peptides are overtaken by renin-angiotensin system, the net result being the heart failure syndrome persists and progresses. Though the natriuretic peptides are increased in number, the increase in the quantity, though they are beneficial, they cannot contribute, they cannot decrease the syndrome of heart failure in a normal person, with a patient with heart failure, because their turnover is also high and because they are overtaken by the renin-angiotensin and sympathetic nervous system. So again, to recapitulate, sympathetic nervous system causes vasoconstriction, renin-angiotensin system will lead to the sodium retention, whereas natriuretic peptide system will lead to natriuresis, but this will predominate. If you see the present day treatment, I am sure, though this is not the topic of discussion, most of you know the beta blockers, ACE inhibitors, they counteract the increased sympathetic nervous activity and renin-angiotensin system and try to improve the natriuretic system. Now, the compensatory mechanism to start with, they are important to preserve the blood pressure and the cardiac output. So all these things, Frank Sterling's mechanism by increased preload, neurohumoral activation, intravascular activation, they're all good to start with. They maintain the blood pressure. But over a period of time, they become maladaptive. That is the crux of the heart failure syndrome. The initial compensatory mechanisms become maladaptive, leading to ventricular remodeling, myocyte death, and valvular regurgitation. Now, this cartoon shows the normal myocardium. This is the area of infarct. For a period of time, this becomes thinned out and expands. The other areas which are healthy, they'll have to bear the increased volume overload. This leads to eccentric hypertrophy. At a cellular and genetic and cellular changes occur. These areas expand along with the change in the thinning and further expansion of the infarcted area. This is what we call remodeling. The elliptical size of the ventricles becomes globular and circular. Now, along with the ventricular remodeling, there will be increased mitral regurgitation because of the tethering of the leaflets and restricted opening, and mitral annulus is dilated and distorted mitral apparatus. This leads to mitral regurgitation, and we know mitral regurgitation begets mitral regurgitation. Over a period of time, this contributes to the worsening of the heart failure. And also, because of the interstitial fibrosis and loss of the myocytes by the fibrous tissue, there will be the circus movement of the ectopics, the tachycardias, and leads to stretching of the, leading to various arrhythmias, and atrial stretching also leads to electrical instability, and atrial fibrillation, ventricular arrhythmias are very common, and they precipitate heart failure, and atrial fibrillation also leads to thromboembolic phenomena. And also because of the fibrosis and chamber dilatation, bundle branch blocks appear. LBB is particularly common following old previous interval infarctions, and this decreases the synchrony and leads to worsening of the heart failure. And combination of these arrhythmias and bundle branch blocks lead to the progression of the worsening of prolongation of the QRS and re-entry tachycardias, and sudden cardiac death is common in these patients. Just to recapitulate, various pathophysiological mechanisms are there. At a cellular level, molecular level, there will be abnormal excitation, contraction, coupling. Beta-adrenergic desensitization will be there because of the sympathetic activity. This leads to hypertrophy, necrosis, fibrosis, and apoptosis. And we discussed about the remodeling, dilatation, and increased sphericity, and also annular dilatation and mitral regurgitation. There will be acute intermittent ischemia and hibernation, bionic myocardium, and arrhythmias and altered ventricular contraction. The various biochemical factors include renin-angiotensin and all these things we discussed. In addition, there will be problem with the cytokines, the tumor necrosis factors and increase will be there, and interleukins are altered metabolism will be there. Especially these lead to cardiac cachexia. In addition to this, genetic background, gender, age, environmental factors including alcohol, tobacco, and toxic drugs, all these contribute to the pathophysiology of the heart failure. In addition to comorbid conditions like diabetes, hypertension, renal disease, anemia, obesity, all these contribute to the progression of the heart failure syndrome. Now, this is all about the heart failure with reduced ejection fraction. Now, what is heart failure with preserved ejection fraction? This is one of the many mechanisms, but it will let you understand. One of the common risk factors for heart failure is hypertension. A long-standing hypertension can lead to heart failure by two different mechanisms. It can be a risk factor for the coronary artery disease and myocardial infarction, which progresses to systolic dysfunction and heart failure. Whereas the hypertension, when it is associated with obesity and diabetes, and not with smoking and here dyslipidemia, but hypertension is obesity and diabetes, which the patient doesn't have MI, but will over a period of time develop left ventricular hypertrophy, diastolic dysfunction, and heart failure. This is what we call heart failure with preserved ejection fraction. Now, this is the cartoon here. The systolic heart failure will be chamber will be dilated, the dysfunction, systolic dysfunction, whereas in diastolic heart failure, ejection fraction will be preserved, chamber size will be preserved, but the ventricular muscle will be hypertrophied, and this will lead to the diastolic dysfunction. Now, unlike heart failure with reduced ejection fraction, heart failure with preserved ejection fraction is not one entity. It is actually not a cardiac failure. It is a systemic failure. It is a systemic disorder. The whole cardiovascular system is failing. It's not just confined to the myocardial function or structure or function. Here we see this is seen more commonly in increased age and female predominance. So many comorbid conditions will be there like overweight, obesity, diabetes mellitus, metabolic syndrome, hypertension, renal dysfunction, COPD, anemia. Here, these lead to pathophysiological mechanisms which include the right ventricular dysfunction, pulmonary hypertension, chronotropic incompetence. They can't increase the heart rate, impaired systemic vasodilatory reserve, and ventricular vascular stiffening, some element of systolic dysfunction, and arrhythmias like atrial fibrillation, which are fairly common in heart failure with preserved ejection fraction. It is the pathophysiology of heart failure with preserved ejection fraction is little very big topic, and I may not be able to discuss everything, but we'll look at some of the aspects. One of the common problems in this heart failure with preserved ejection fraction is the availability of the nitric oxide in the endothelium. When the nitric oxide bioavailability is reduced because of the oxidative stress or metabolic abnormalities, there is a reduced downstream signaling with reduced cyclic guanosine monophosphate and protein kinase Z activity. This leads to myocardial hypertrophy, cardiomyocyte stiffness, and interstitial fibrosis at a cellular level, myocardial level. This is one of the physiology from physiology rays. You remember, as the diastolic volume increases, the diastolic pressure also increases, pressure volume relation. In diastole, normally we see it is here lower down, and the rise in the diastolic pressure is much lower with increasing diastolic volume. But in a patient with diastolic dysfunction, at a lower volume, one has higher pressure, and with a lesser increase in the volume, the diastolic pressure increases further. So this is what happens in heart failure with preserved ejection fraction. Basically, the chambers, left ventricle or right ventricle, become stiff. So with limited increase in the end diastolic volume, the pressure rises and the congestive symptoms increase. Another important concept to understand is the ventricular arterial coupling. So what is it? It is the downstream transmission of the energy generated. So the ventricle, when it contracts, it generates so much of energy. That's how the pressure is increased in the to the blood volume. So when this generated pressure has to be transmitted lower down into the aorta and the vascular tree. How efficiently this occurs, that is the better it is coupled. Ideally coupled is the one where the minimal loss is there. But suppose the vascular system is highly, the elasticity is lost and it becomes stiff, then the energy produced in the left ventricle is not properly transmitted. So there will be a ventricular arterial coupling will be, decoupling will be there. So the energy will be deranged, and it lead to both decreased perfusion as well as the increased pressures, congestion, filling pressures. These are the pressure volume loops. Probably trained cardiologists will understand. It may be a little difficult for physicians, but there is nothing unusual or great. Here on the x-axis, you see the left ventricular volume. Here on the y-axis, you see the pressure. In a cardiac cycle, normally the volume increases in diastole, then it builds up the pressure. Then after that, at the end, once the aortic valve opens, the volume decreases while the pressure remaining constant. And with isovolumetric relaxation, the pressure decreases, and again the diastole starts. This is called a pressure volume loop, and this is what we call a load independent index of the ventricle. This is very important marker to understand how the heart failure with preserved ejection fraction increases. Suppose we draw the pressure volume loops of a ventricle with different degrees of the volume or different elevation of pressures. We have got charts like this. This portion is end systole. If you draw a graph of a ventricle with different volumes and different pressures, you have a straight line. This is called end systolic elastance. In heart failure with ejection fraction, this becomes stiff. So this is important to understand. Basically, the whole cardiovascular system becomes stiff. So what is the result of that? If there is an increase in the volume with minimal change in the volume, in the blood volume, the person will have higher pressures and will have a decongested state, decompensated heart failure, manifest heart failure. Suppose you decrease the volume, blood volume, you decrease a little bit, then suddenly there will be hypovolemia, azotemia, and patient will have hypotension. So basically in heart failure with preserved ejection fraction, the slope of the end systolic elastance becomes stiff, which means the whole cardiovascular system becomes stiff. So changes in volumes of the blood volume will lead to problems. So in clinical practice, the patient comes with the heart failure, you give a little bit of diuretics, suddenly the pressures drop and patient will go into azotemia, creatinine goes up. You be liberal with the fluid, patient goes into heart failure. This is the pathophysiology of the heart failure with preserved ejection fraction. Now, the various mechanisms are there, central and peripheral. We have got the central mechanisms, as I mentioned, because of the hypertrophy and stiffness, you have got both increased LV, RV fillings, filling pressures are increased. There is exercise tolerance is decreased, and load to sensitivity, just now I discussed. This will lead to LV diastolic stiffening and RV dysfunction. Some element of LV systolic stiffening will be there. And because the chambers, especially atria, are dilated, atrial dysfunction and atrial fibrillation contribute. These are the central mechanisms in heart failure with preserved ejection fraction. The peripheral mechanisms are equally important because heart failure with preserved ejection fraction is not a pure myocardial disease, it's a systemic disease. In kidneys, you have got renal retention and arterial stiffening. As I mentioned, diabetes, hypertension are very common and comorbid conditions are there. Pulmonary venous hypertension, impaired diffusion capacity, and reactive hypertension, pulmonary hypertension are seen. COPD is often seen in these patients, and also obesity with obstructive sleep apnea is common. We have got the peripheral mechanism, endothelial dysfunction will be there, leading to coronary and systemic microvascular rarefaction will be there, autonomic dysfunction, all these contribute, and also skeletal muscle myopathy is seen. So heart failure with preserved ejection fraction is a multi-system disease. Again, it's basically a disease of aging. With aging, you have got hypertension, sedentary lifestyle, exercise capacity decreases, person doesn't exercise. They lead to obesity and metabolic stress. Hypertension leads to ventricular and vascular stiffening. All these interact with each other, and there's a global loss of cardiac, vascular, and peripheral reserve, leading to heart failure with preserved ejection fraction. So we have discussed till now both heart failure with reduced ejection fraction as well as heart failure with preserved ejection fraction. This is a big topic. We can't discuss elaborately. This is only a nutshell. So finally, we have to understand pathophysiology of a disease helps us to discover treatment strategies. As I mentioned, the maladaptive renin-angiotensin system, maladaptive sympathetic nervous system, and all these things lead to the heart failure. When we are treating with renin-angiotensin blockers or beta blockers, we are basically countering the maladaptive processes. And heart failure is reduced ejection fraction, a progressive disease. Why should it be progressive? Because of the maladaptation and also continuing genetic and molecular mechanisms would change the phenotype, and further understanding of these genetic changes at a molecular and cellular level will give insight into the heart failure syndrome, why it progresses, and probably in future we'll be able to prevent the progression of the heart failure. And as I mentioned, heart failure with preserved ejection fraction is totally different from heart failure with reduced ejection fraction. Thank you very much.
Thank you, Dr. Sastry. So, shall we have the next talk and have the discussion at the end, or shall we have some discussion now?
Whatever you want, sir. Whatever you say. Professor Vijayaraghavan was saying something, I think. Unmute, sir. Unmute yourself, your system.
Is it working?
Yeah.
Hear me?
Yes, sir.
Yeah.
Can you hear me?
Yes, sir. We can hear you.
Yeah, we can.
I think we'll have the next talk and then take both of them together for discussion.
Yeah, okay, sir. Sir, sharing your screen.
Yeah, I will go ahead with my presentation. Yeah. Anyway, thank you, Dr. Harikrishnan, for this invitation to be amongst you this evening for this heart failure symposium. And I think my job is because these are some of the last next to the last talk, so probably most of the things would have been already covered. So there could be an overlap wherever there is overlap, because Professor Sastry has already given a lot of insight into pathophysiology. In that process, even there will be overlap that I will try to just skip. So the important key considerations and objectives of clinical evaluation of heart failure are, any agenda whenever we are talking about heart failure obviously includes, we are looking at what is the incidence of heart failure that you have already alluded to, how to diagnose heart failure, and what should be the bedside assessment of both acute heart failure particularly and also a chronic heart failure. What are the newer paradigms in heart failure assessment? So these are some of the important subgroups we need to discuss. So this has been already discussed once again. The definitions of heart failure is the complex.
Can you share your slides?
Yeah. So this is a usual definition of heart failure resulting from any structural or a functional cardiac disorder that impairs the ability of the ventricle to fill with or eject. That means this definition includes both systolic heart failure as well as diastolic heart failure. The impaired contraction refers to a systolic heart failure, and impaired relaxation or what is called lucid trophicity of the heart. Impaired relaxation is represent diastolic heart failure. In some, obviously, there is both systolic as well as diastolic heart failure. So the cardinal manifestations and the symptoms of heart failure, the two important principal symptoms of heart failure is dyspnea and fatigue. So dyspnea always because of increased pulmonary capillary wedge pressure, and fatigue represent decreased cardiac output. Then impairment, it could be in form of functional capacity also, which adversely affects quality of life. And circulatory failure is not synonymous with heart failure, because circulatory failure can be due to non-cardiac conditions. It could be due to hemorrhagic shock or septic shock. So circulatory failure is not synonymous with heart failure. And this has been already alluded to. Backward failure and forward failure or historical terms, nowhere it is used. And if you look at the epidemiology of heart failure, already it has been nicely covered by Dr. Harikrishnan. This is the most common cause of hospitalization, and this has been already said. The first-year mortality is very high in Indians, what you said, and 5 years it is around 50 to 60%.
Sir, sorry to interrupt. Do you have slides or we are not able to see?
Yeah, I am slides only. I am giving slides only.
But we cannot see, sir. Can you share screen?
Okay. 1 second. Slides to share.
In that there is a share button in the middle. Share content. In that share content and open the power. Use that share content. Yeah.
Are you seeing? Now you are seeing?
Yeah, it's coming, sir. It's coming.
Okay, sorry.
Yeah, now it is coming, sir. Make it a full screen.
Not going.
Make it a show.
Sure.
Yeah, sir. Coming. Thank you.
Okay, fine. So the measuring the impact of heart failure, 5 years adjusted mortality has been already said is around 45 to 50%, and readmissions rate are 46% within 3 months of discharge and 54%. This is just a sort of an introduction. So if you look at the evaluation of heart failure, you have to identify who are all the patients at risk for heart failure. In other words, you have to always explore the step A. Then determine the type of cardiac dysfunction, whether it is a systolic dysfunction or a diastolic dysfunction. And you need to determine the etiology. And most important is, again, looking at what are the precipitating factors and define the prognosis and guide the therapy. So these are some of the important key considerations when we are taking a particular patient for evaluation of heart failure. The patients at risk for heart failure, this has been already alluded, that is hypertension, diabetes, coronary artery disease, obesity, metabolic syndrome, valvular heart disease, exposure to cardiotoxins, particularly those who are some chemotherapy, they are known to cause cardiotoxicity and heart failure, and family history of cardiomyopathy. These are some of the things we should look when you are trying to look at risk for heart failure. So what is left ventricular systolic dysfunction? That impaired contractility or ejection is approximately 50% of heart failure patients have a systolic dysfunction. And then diastolic is basically, of course, it depends on the etiology, because diastolic heart failure is more often with hypertension, diabetes, even with CKD, where there is an impaired relaxation and impaired filling. In other words, the lusitropic component of the cardiac contraction is affected. The lusitropic dysfunction causes diastolic heart failure. So if you look at the etiology and comorbidities on the left panel, you can see 2/3 of heart failure is due to coronary artery disease, and dilated cardiomyopathy comes next. Even you also presented similar figures. Valvular heart disease, hypertension, alcohol and other toxins, myocarditis, infiltrative disorders. Particularly, you have to look at amyloidosis, sarcoidosis, and also even hemochromatosis. Then comorbidities would be diabetes, hypertension, renal insufficiency, and sleep apnea. I think this is one of the important things we have to consider in patients with heart failure or in patients with hypertension, where unless we recognize the sleep apnea as an entity, unless you treat that, even if you treat other components such as they become refractory to treatment, whether it is hypertension, heart failure, or even the coronary artery disease, then pulmonary hypertension of any cause. What are the important triggers? We have acute sudden onset triggers and a chronic gradual onset triggers. What are those acute triggers? One is ischemia, arrhythmia, particularly atrial fibrillation in patient with particularly diastolic heart failure, or those situations where atrial contribution is extremely important. But what are those? Those with hypertension, those with aortic valve disease, those with concentric hypertrophy of any cause, where particularly atrial fibrillation or hypertrophic obstructive cardiomyopathy, even a stable hypertrophic cardiomyopathy patient can get into pulmonary edema with the onset of atrial fibrillation. So even complex arrhythmias, sustained VTs can cause worsen heart failure, can result in VT storm, can also, it's a different subset. Then infection, pulmonary embolism, and acute valvular insufficiency, acute aortic regurgitation, acute mitral regurgitation can also cause an acute heart failure. Then chronic gradual onset triggers. One is anemia, thyrotoxicosis, non-compliance, and diet, particularly those diet rich in salt and non-steroidal and inflammatory drugs. Then what are the symptoms and physical signs of left ventricular dysfunction? But I am talking about LV systolic dysfunction. Dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, cough, hemoptysis, nocturia. In fact, hemoptysis is more common in acute on chronic heart failure or in an acute heart failure, because there is a sudden rise in capillary wet pressure results in hemorrhage, alveolar hemorrhage. So hemoptysis more often in acute heart failure or acute exacerbation of chronic heart failure. Then physical signs would be tachycardia, basal rales, pulsus alternans, S3 gallop, pleural effusion, and some abnormal respiratory pattern. So what are the trying to explain some of the symptoms of LV dysfunction. Dyspnea, origin is multifactorial. Accumulation of interstitial or intra-alveolar fluid stimulates juxtacapillary J receptors, abnormal pulmonary compliance, airway resistance, respiratory muscle fatigue, anemia, because anemia is one of the important contributing factor for worsening of heart failure, particularly in our country. Nearly 30 to 40% of patients with heart failure do have anemia. So there is some grading with respect to the grades of dyspnea versus the pulmonary capillary wedge pressure. Grade 1 dyspnea obviously will have a normal pulmonary capillary wedge pressure, and grade 2 dyspnea, the dyspnea on moderate exertion will have a wedge pressure of 12 to 18, and grade 3 dyspnea will have a wedge pressure somewhere between 19 to 24, and grade 4, that is dyspnea at rest, means obviously the pulmonary capillary wedge pressure is more than 25 millimeters of mercury. And what are the other specific symptoms? Paroxysmal nocturnal dyspnea is a symptom of left heart failure, because we always say it is a symptom of left ventricular failure. It could be also a symptom of left heart failure. For example, in mitral stenosis, we get paroxysmal PND. That we can't say it is a left ventricular failure, because in mitral stenosis, left ventricle is protected and it is a left atrial failure. So in broader term, PND is a symptom of left heart failure. Then a nocturnal cough, frequent but overlooked. Cardiac asthma closely related to paroxysmal nocturnal dyspnea. Wheezing is due to a bronchospasm. So many a time we are in a dilemma between a bronchial asthma as well as cardiac asthma. I think this is one of the important practical differentiation, because many a time if you treat bronchial asthma as cardiac asthma, we'll run into problem. and vice versa is also true. For example, of course, in olden time, when it comes to a question of giving analgesia, if you give morphine for bronchial asthma, it causes a catastrophic event. And of course, for cardiac asthma, still morphine is one of the best. So I think clinically we should be able to differentiate bronchial asthma from cardiac asthma. I think best is the history, and in a bronchial asthma, between the wheezing, in between the free wheezing period, they're absolutely normal between the episodes. And of course, history of hypertension, history of ischemic heart disease on clinical examination. If you have a cardiomegaly, if you have a LV apex, if you have atrial fibrillation, all points to a cardiac asthma. While X-ray also will be of great help in this situation, because this is a practical issue. A small heart favors a bronchial asthma, and a emphysematous chest favors a bronchial asthma. And on ECG, if we see a left ventricular hypertrophy, or if there is a left atrial enlargement, it goes more with cardiac asthma. While if you see a, usual COPD pattern of ECG, or if there's a right atrial enlargement, it goes more with the a bronchial asthma. These are some of the important things. Atrial fibrillation always more often with a cardiac asthma than with the bronchial asthma. Then cane stroke, sometimes there is what is also called platypnea. What is called as extreme, when cardiac index is markedly reduced, they can have bendopnea. That means whenever they feel, go forward, when they lean forward, there is a lot of breathing difficulty. Always suggest bendopnea is a symptom of advanced heart failure. So also cane stroke respiration due to low cardiac output. What are the conditions that simulate paroxysmal nocturnal dyspnea? I think this is an important practical consideration. Nocturnal episodes of asthma, because the etiology, the underlying mechanism is different between PND and other, simulators. One is nocturnal episodes of asthma, sleep apnea with arousal, because they get into sleep, then because of sleep apnea, they get up. So many a time the sleep apnea, people are treated with diuretics, there is worsening of sleep apnea. So, this is where this demarcation is important. Post-nasal discharge with severe cough, nocturnal angina with dyspnea as angina equivalent, nocturnal episodes of recurrent minute pulmonary embolism, and anxiety with hyperventilation. So these are some of the important stimulator, which exactly match with PND. We need to differentiate. So these are some of the important things which can simulate as PND. We can mistake them as PND and wrongly treat, end up in worsening of their usual issues. So the physical examination, the auscultatory features, if you get an S3, it is present in patients with volume overload, signifies severe hemodynamic compromise. Persistent S3 predicts poor prognosis. So particularly if there are regurgitant lesions such as mitral regurgitation, S3 in mitral regurgitation doesn't always suggest LV dysfunction. It is all because of increased filling, but otherwise a persistent loud S3 always suggests a systolic LV dysfunction and also predicts a poor prognosis. S4, not specific indicator of heart failure, but an important thing, auscultatory finding in patient with diastolic dysfunction, tachycardia, cardiomegaly, murmurs. This is again an important issue. A patient is in respiratory distress. If you are hearing some murmurs, particularly mitral regurgitation murmurs or mitral stenotic murmur, or aortic valve murmurs, then it is a cardiac issue. Then pulmonary findings, we have RALS is because of transudation of fluid into alveoli specific for heart failure in the absence of lung disease. Pleural effusion, again a part of advanced long-standing heart failure. in particularly with biventricular failure, and pleural veins drain to both systemic and pulmonary veins. That is the reason many a time it is an important finding, usually bilateral, more frequently on the right. So what are the symptoms and physical? When once a long-standing left heart failure persists, it results in right heart failure, or there could be a de novo right heart failure, or it could be a virgin right ventricular failure, depending on the cause. So what are the symptoms of right ventricular failure? One is anorexia, nausea, early satiety, bloating, abdominal pain. It can be even ascites, swelling of the legs, and nocturia. Then the physical findings would be peripheral edema, jugular venous distension, abdominal jugular reflux, hepatomegaly, ascites, jaundice, cardiac cachexia. So when patient has got a full-blown right ventricular failure, more often we see a peripheral edema and hepatomegaly, jaundice, ascites. So edema is a common symptom, and increased venous pressure, abnormal activity of salt-retaining hormones, and they can always put on somewhere between 2.5 to 4.5 kgs of excess fluid, and recent vein gain correlates with worsening of clinical status. So what are the signs and symptoms of low cardiac output? Fatigue is obviously a symptom of low cardiac output, tiredness, fatigue and tiredness, and drop in urine output. Then we have physical signs, cold extremities, peripheral cyanosis, narrow pulse pressure. So low cardiac output also causes other symptoms such as mental confusion, disorientation, sleep and mood disturbances, more common in elderly due to cerebral atherosclerosis and decreased cerebral flow. Then cardiac cachexia, again seen in long-standing chronic severe heart failure, again a marker of poor prognosis, and marked weight loss, again multifactorial, elevation of resting metabolic rate, anorexia, nausea, vomiting due to congested liver and stomach, so also due to drugs also, because of digoxin can cause nausea and vomiting, but more often it is due to congested liver and stomach mucosa, impaired intestinal absorption, increased inflammatory cytokines. Pulse in heart failure, sinus tachycardia, support of sympathetic activity, small weak arterial pulse suggests a low stroke volume, so narrow pulse pressure due to high diastolic blood pressure, a generalized vasoconstriction, and a marker of low cardiac output, and high pulse pressure in high output state. I will not get into that. So in those with pulses alternate, those severe LV dysfunction, that is an alternate strong and weak, it basically better appreciated of course, it's best, all pulses alternates are, best felt in the peripheral pulse, maybe radial or femoral rather than central pulses, confirmed by sphygmomanometer. Of course, on hemodynamic tracing, it will be obvious. So dicrotic pulse, twice peak pulse, first in systole, second in diastole, best felt in carotids, again severe LV dysfunction. So what are the limitations of physical signs in heart failure? Not necessarily every patient of chronic heart failure can have RALS, can have pedal edema, can have pleural effusion. So RALS indicates heart failure of rapid onset. In chronic heart failure, more often you don't see RALS, don't auscultate RALS, absent in most patients with chronic heart failure. Interstitial, the reason why you don't hear RALS in chronic heart failure, because interstitial fluid is removed by increased lymphatic drainage, and peripheral edema is absent in at least half of the patient with intravascular fluid overload. Heart failure in elderly, exertional dyspnea is less frequent, occurs later because of decreased activity, because more often their physical activity is restricted. Orthopnea, PND less common, age-related pulmonary vascular changes. Atypical symptoms are common: cough, lethargy, confusion, falls, dizziness, insomnia, anxiety. These are some of the atypical symptoms we see in elderly patients with heart failure. And of course, this has been already said. We have three, grades of heart failure classification based on ejection fraction, already covered. And typical patient with heart failure with preserved ejection fraction is an elderly woman with history of hypertension, often with diabetes. Heart failure is episodic, often precipitated by an episode of atrial fibrillation, ischemia, or infection. Even for another typical example of diastolic heart failure is a flash pulmonary edema also, or an hypertensive acute left ventricular failure. So look at the signs and symptoms of heart failure with respect to sensitivity and specificity. Dyspnea is the most consistent symptom. So also orthopnea, with respect to specificity, and PND, edema. All these symptoms and signs do not occur in majority in one patient. So JVP, again, a high specificity, but again, a low sensitivity unless you look for if they are already on diuretics, if they are already on the medication. These are some. So in this situation, I think X-ray and echo give lot of additional inputs with respect to making a diagnosis. So Framingham criteria, this has been already alluded to. These are the major criteria which we have already discussed, and you can see here. So this is what, when patient is in frank right heart failure, it is a pulsatile jugular venous pressure, and we can always see this. Then we have minor criteria, nocturnal cough, dyspnea on exertion, bilateral ankle edema, heart rate more than 120 per minute, hepatomegaly, pleural effusion, vital capacity reduced by 1/3. So weight loss of more than 4.5 kg is also in response to treatment is also a major or minor, at least one major and two minor criteria required to establish a diagnosis of heart failure. So can I have some time whether I should conclude, Dr. Hari, because already we are into 9 o'clock.
So you can continue for five more minutes and then we will wind up, sir.
Okay. So then we have this hemodynamic assessment of acute heart failure. We always talk about whether it is wet or dry, whether warm or cold. So wet means always they have a high filling pressure. In other words, they have elevated pulmonary capillary wet pressure, and X-ray always shows some changes. And if it is, then we also talk in terms of whether warm or cold, that suggests a perfusion. So one is elevate in an acute heart failure. Two things are important. One is perfusion, end organ perfusion, and the other one is elevated filling pressure. So if elevated filling pressure is high, we call it as wet, and the elevated filling pressure is normal, then we call it as dry. If perfusion is good, then it is warm. If perfusion is reduced, when we cold, it has got a therapeutic implication. If it is a wet type of heart failure, then we have to give diuretics. And if it is dry, then they don't require diuretics. If at all, if they require, it's less. If it is cold, that means it is a low cardiac output. They need more inotropes and more myocardial support. So of course, if it is wet, then evidence of congestion such as orthopnea, edema, and S3 or else. If it is cold, then it is low perfusion in form of hypotension, narrow pulse pressure, cold extremity. That is the reason if in a heart failure patient, if extremities are cold, that suggests it's a low output. If extremities are warm, that is the importance of physically examining the patient, and you should not try to treat only you should not treat only investigation, you should not treat only images, you should not treat only echo. And so just if extremities are warm, means reasonably cardiac output is good. If extremities are cold, then it is low output state. So this has been already, functional classification has been addressed. Nearly 35% of patients fall in class 1 NEHA, then another 35% into 2. So the more often patients with heart failure present in 2 or 3. So the investigations is important. Why I am emphasizing is hemoglobin. I think this is one thing in our clinical practice, all of us agree we have to, because today our younger generation more often write HbA1c rather than hemoglobin. You just correct this hemoglobin, many a time, many of these patients feel a lot better. Even iron deficiency, anemia is more often seen. And anemia, iron administration is not just for anemia correction, it improves the overall the performance of the heart, and also the patient feels a lot better because iron has a lot of advantages beyond anemia correction. Then urea, creatinine, electrolytes is a must because we give a lot of drugs. I mean, hypokalemia is important. Whenever you give ACE inhibitor, CRB with aldosterone antagonist, there can be hyperkalemia. And NT-proBNP is both diagnostic as well as it guides the treatment and guides the response. And ECG, I've already said, X-ray chest is simple. In fact, if the diastolic heart failure many a time is well appreciated on X-ray chest than on because echo shows a normal systolic function. If there is a pulmonary venous hypertension on X-ray, yes, diastolic heart failure is definite. And echo already must have been discussed. And chest ultrasound, many a time small pleural effusion we underestimate on X-ray chest. If you do a chest ultrasound, we see 500 to 700 ml of pleural effusion. Then removal of this pleural fluid itself improves a lot of symptoms. MRI, yes, is also an important thing, particularly to assess myocardial fibrosis. And another thing, MRI, to differentiate between ischemic cardiomyopathy versus your dilated cardiomyopathy and sarcoidosis, it plays an important role. If it is a subendocardial fibrosis, goes with ischemic cardiomyopathy. And if it is mid-septal or mid-myocardial, then it is dilated cardiomyopathy or pericardium cardiomyopathy. So all this information you can always obtain from this. This is an ECG. Always in a left ECG findings of chronic heart failure will be any one of this. It could be sinus tachycardia, particularly acute heart failure. Then it can left atrial enlargement. There may not be LV hypertrophy depending on the cause. It can be in a dilated cardiomyopathy that will be sinus tachycardia and a low voltage complexes. There can be arrhythmias such as VPCs, non-sustained VTs, atrial fibrillation, and QRS. As QRS is widening, then obviously myocardial dysfunction, dyschrony is setting in, and this has got a clinical relevance because QRS duration more than 130 with always it can come. I will not get into that. I think in the interest of time, I will skip these slides. Importance of IVC is important, because then you know that if IVC is dilated, then they require a lot of diuretics. So this clinical characteristics has been already addressed. I will not again repeat in the interest of time. Staging has been done, and complement, do not replace NYHA classes. NYHA classes keep shifting back and forth in individual patient in response to drugs and progression of the disease, and progress in one direction due to cardiac remodeling. That has been addressed. And changing paradigm. In fact, at Jayadeva Institute of Cardiovascular Sciences, we have taken this digital stethoscope to look at ECG, and it also calculates ejection fraction calculation and diagnosis of murmurs. So usage and also diagnosis of atrial fibrillation. And our electrophysiology department, Dr. Deepak Padmanabhan and Dr. Jayaprakash, have taken this particular study with this eco-core digital attachment and also digital stethoscope. It calculates, that means in other words, usage of artificial intelligence. Also remotely we can monitor their symptoms, their ejection fraction, their systolic time intervals, and also the murmurs and arrhythmias, and also this automated seismocardiographic measurement of systolic time intervals in LV dysfunction, validation with transthoracic echocardiography has been undertaken. So I think in maybe 3 decades back, we were talking about systolic time intervals. We're using phonocardiography. I think this is coming back in form of artificial intelligence. So recording of ejection fraction, systolic time intervals using ambulatory seismocardiogram has a lot of clinical implications. So summary, heart failure diagnosis is clinical. Heart failure with reduced ejection fraction, it could be compensated or decompensated. And heart failure with preserved ejection fraction is another important entity. Use of technology to drive bedside diagnosis. So again, a clinical examination still is relevant, and I mean, you have to focus, give some importance to ECG and X-ray reading and echocardiography. Professor Vijayaraghavan, I am seeing here, is one of the father figure of echocardiography in our nation. I think a good cardiologist, is my opinion, is a good echocardiographer. If you are a good echocardiographer, you could be a good clinical cardiologist, and also it guides your interventions also. So thank you very much. Hello, Dr. Hari.
Audio has a problem.
Yeah, it is done.
So please stop your screen.
Hello, can you hear me?
Yes, sir, please.
Yeah.
Hello, Hari. Need to summarize the day.
Hello. Yeah. Can you stop sharing, sir?
Stop sharing. Stop sharing.
Okay. Hello.
Yes, go ahead, please.
Yeah, over to the moderators for the discussion.
Yeah.
We have 10 more minutes. I think we can. We have exceeded time little bit. But we question was to Vijayaraghavan, sir. What was the name of the autobiography? Some question was there.
I answered that. Can you hear me?
Yes.
Yeah. Dick Cheney, former vice president of the USA, who had heart attack during his time as a vice president, and then he had every mode of therapy for him: angioplasty, pacemaker, CRT, then HeartMate 2, and finally transplantation. But the most important thing in the description is that with HeartMate 2, he moved around the whole of USA for the election campaign. And that shows the impact of a HeartMate 2 in an individual, even without transplantation, for quite some time, at least for a year or two in the ideal patient.
So, what was the name of the autobiography, sir? That was the question.
I have it. I don't remember the name. Every bookstore, if you look at it, has the Dick Cheney's autobiography.
Okay, sir.
There is a question about the sacubitril valsartan usage as a first line versus isosorbide hydrogen because of the cost considerations. Dr. Vijay Chopra has answered that, though it is not today's topic. Since the question was raised, I think we should answer. I would say briefly that, well, in short term, it may be expensive, but definitely it has got good effect on the morbidity, mortality, hospitalization. We know one hospitalization will shave off all the money the patient would have saved. So as far as possible, one should give sacubitril valsartan unless there is a serious problem. In the short of it, one can try good dose of ACE inhibitors, enalapril maximum dose or ramipril maximum dose, and isosorbide hydrogen should be the lowermost in the treatment chart. Maybe others can comment.
I don't think we have evidence to show that in Indians, isorbide dinitrate and hydralazine do change the course of the heart failure. Many of us use it when other mode of therapy is contraindicated. We do not have enough evidence that in Indians it's going to be useful. In the US, the only evidence is that in blacks it produces more relief than in whites. For them, that more research work is required whether this cheap treatment is going to be useful in these patients.
Dr.
All the
Vijayaraghavan,
drugs are contraindicated. This is one mode of treatment.
yeah, Dr. Vijayaraghavan, even that was a very small study, and it was published, but then subsequently, since it went off label, nobody did any work on that.
I know that. Yeah.
Yeah, recently there has been indications that maybe we need to do more work on that. It's a cheap therapy, and if it improves outcomes, especially in people who have contraindications to ACE and ARB, then why not? Hemodynamically, it has got preload and afterload reduction, which seems to be sound clinical basis.
I agree. Only contraindication is basically the side effect of either the hydralazine, sometimes isobar dinitrate. Hydralazine is not tolerated by all patients. They will have nausea, vomiting, and problems with hydralazine. But at the same time, this is one drug which is tolerated reasonably well, and contraindications are hardly any. Very few contraindications to this drug. You take ARNI, you should have a normal renal function. The creatinine clearance has to be more than 30. Otherwise, you can't use ARNI. Plus, ARNI, at least in about 10% of patients, produces profound hypotension, that which has to be, especially when there is any tendency for hypovolemia, and that has to be sensed correctly and should be treated and drug withdrawn. So these side effects have to be very much highlighted to the public. As I said earlier, we found more than half the patients cannot have ACE inhibitor, ARBs, or beta blockers, and even ARNI because of these contraindications. And we should remember the guideline directed treatment is optimally available only for 50% of patients if you look after all the contraindications and do it correctly on the proper with the proper perspective. That's the main problem in cardiac failure.
We don't have solid data, but we have
Blood
used
pressure is
it
not correct,
extensively in
or the
patients
heart
of
rate is not
renal
correct,
failure.
or potassium is not correct, or the renal function is not correct.
Yeah. There was one question from somebody. Heart failure with preserved ejection fraction is relatively less in India. Could it be because of under-reporting?
That's what I highlighted during my discussion, because physicians are not recognizing the heart failure with preserved ejection fraction at the right time and documenting it. That could be the reason. So more physician education is required.
Oh, sorry.
Okay, anybody else? Any comments?
Dr. Harikrishnan, may I speak a few lines?
Please.
Doctor. You see, we have heard Dr. Manjunathan and Dr. Sastry on the pathophysiology of heart failure. It would be more enlightening to us if we can add how the pathophysiology is impacted by various guideline-directed therapies. And then this thing, say we are giving a cardiac resuscitation therapy and some of the patient ejection fraction improved by various pathophysiological mechanisms. And by knowing these, how pathophysiology is impacted by various treatments, we can know how long we can give the therapy to the patient. And that will have a better insight in our understanding. Am I clear, sir?
Hello, Dr. Sastry, can you please answer?
There's no doubt. That's what. If you take into each one, it becomes a bigger topic because you have to compress everything in 20 minutes. There's absolutely no doubt in what you mentioned, sir. For example, we can discuss about how the beta blockers are initially contraindicated, then they became indicated, looking at the pathophysiology, the maladaptive process, whether you're talking about the neprilysin inhibitors, then if you're talking about the asynchrony, mitra clip, we can go to any extent. So in order to compress the time, in compressing that in the given time, and also looking at the audience, the level of, at what level you should tell, I compressed it, but you're absolutely right. We could have reorganized, for example, how the LBBB decreases the onset of LBBB, how it decreases the contractility, how the CRT will help, what is the basic nature of the progression, and you start with diuretics and keep on increasing as ACE inhibitors and beta blockers, keep increasing the dose, then bring in sacubitril valsartan, then CRT, then mitra clip, then transplantation. All these things, I agree with you. For want of time and considering other topics, sections, other lectures in future, I didn't elaborate, but you're absolutely right.
Thank you, sir.
I think there was a very interesting talk by Milton Packer long back, I remember, trying to define heart failure. He said initially it's a disease of dropsy, edema. And it turned out to be a disease of the heart muscle. And it turned out to be a disease of the neurohormonal disturbance. And finally, what we have to look at is an increased apoptosis. The heart muscle, enough is not made for the loss of heart muscle. That's ultimately the reason why the heart goes on to fail. This I thought was very attractive way of looking at what causes really heart failure. Heart disease, increased apoptosis, heart muscle is not replenished, and that goes into failure. Milton Packer did it very elegantly.
Any other questions you have received or?
I think it is dinner time, no questions.
Everybody is hungry.
Okay, then shall we wind up? Because there is a recap session. So whatever questions we have received, we can answer in the next 15 minutes of the next Wednesday. So we have a recap. So whatever questions we receive, we can answer that at that time.
Yeah, that's better.
Yes, Hari. I think
Hari,
that's fine.
it is a pleasure to take part in this program. Thank you.
Okay, sir. Thank you. Thank you, all the moderators and the faculty for joining. And I hope that this was useful to the participants. We are getting some feedback, and we will modify the program according to the feedback received. So far, what we have.
This was useful to us also.
The presenters benefit the maximum most of the time.
Manjunath, how are you getting on?
Yeah, fine.
Okay, thank you.
Okay,
how are you, Dr. Sastry? Fine.
Driver's seat for the state.
Thank you.
Fine.